split S2 and 3/6 ejection systolic mid-systolic murmur at second left intercostal space. So, if this case scenario given to you, it's a very 2 or 3 very important point. First, it's a acyanotic because the room air saturation with pulse oxygen 98%, asymptomatic thin build, wide and fixed split with the ejection systolic murmur left upper sternal border. So with this, if you are telling this, the diagnosis is very clear. Most of the time it's a ASD. So if in the same way, if I show you this ECG with this clinical history, you can see there are 2 or 3. This is only the RSR patient which is related to the dilated RV and the RVOT, and this is the second thing is a crochet arch, that is the splintered or the dip in the QRS in the inferior lid. If these 2 things are there with this clinical history, the diagnosis of ASD is very certain. So one of the reason we already explained in our previous lecture, the reason for incomplete RBB is a dilated RV and the RVOT, which is the last to get activated. That's why the R is small but the R dash is bigger than R. So if you see this X-ray, that is showing clearly RA prominence because it's more than 3 intercostal space, more than 10 cm from the mid-costal line, and there is a end-on vessel. That means it's a plethoric condition, increased vascularity. So any X-ray, if you see, there are 2 things you have to see, whether the vascularity and any different pattern. So the vascularity is increased with the end-on vessel, that means a plethora is there. Plethora is the term used for large left to right shunt. So here with that clinical history, ECG, and this X-ray with the prominent RA and the uplifted apex, RV apex, that is the typical of ASD. So with this case scenario, we are very sure. But if you see the physiology of the ASD, this we already discussed, the more flow will go to the RA-RV, and the RA-RV pulmonary artery will get dilated, and once the blood return to LA, it will not stay, it will immediately shunted to the RA. So the chambers which are getting dilated, RA, RV as well as the pulmonary artery, the same thing will be reflected in the ECG in the form of right axis deviation, RSR dash pattern, on an X-ray the RA and the prominent PA dilatation. So this is there. So this is the first case scenario which shows the importance, although the asymptomatic. So one of the most common disease which remain asymptomatic and can be detected even later age is ASD. And in fact, ASD is the most common congenital heart disease in adult detected for the first time in adult life. Others are bicuspid aortic valve, small PDA, and Epstein's anomaly, mild PS, mild AS. There are the few diseases which can be undetected for long time, and then for something you go to the physician, then they come to know the diagnosis. This is the first case. Second case, in the same way, 3-month-old admitted for pneumonia. This is very important. Child admitted for pneumonia. Started symptoms of breathing difficulty, feeding difficulty, suck cycle, excessive sweating from 6 weeks of age, and had poor weight gain. So if you see this history, history is very clear. Started from 6 weeks when the PVRI drops, then only the shunt increase. That is a typical of large post-tricuspid below the tricuspid, like VSD, PDA, AP window. Second thing, pneumonia. The cause for pneumonia is the microatelectasis due to air trapping because of the increased PA, which is causing the compression on the bronchus and the nidus, and that causes the recurrent RTI. And then second thing, the breathing difficulty, feeding secretion, all are suggestive of CCF symptoms, easy fatigability, and all start of 6 weeks with the fall in PVR. That is very clear. Poor weight gain, that is a typical large left to right post tricuspid shunt, that is known as the cardiac cachexia. The examination is failure to thrive. Now the question comes, what is the definition of failure to thrive? The failure to thrive is described as 2 definitions as per the WHO, when the weight of the child is less than 10 percentile in less than 6 years of age. First. Second thing, and it causes 2 centile line, that in the short period, that is the definition of failure to thrive. It is used only up to 5 to 6 years of age. Weight is only 3 kg in this child with birth weight of 2.8. You can see in 3 months there is no weight gain. Pallor, pulse volume, no radiofrequency, that means coarctation is rule out. Room air saturation 96, that means it's a acyanotic. Intercostal subcostal retraction is because of the increased work of breathing, that means lungs are congested, that's why the work of breathing is high. Respiratory is swell, and the hyperdynamic precordium, short systolic murmur. So once you come about the VSD, once you get the short murmur, that means the VSD is large, pressure is equal on both sides, that will get a short. Once you get the pan-systolic murmur, that is typical of the moderate VSD. And where there is a very short systolic, either it's a very small or very large VSD, that is the typical of that. So if you see this X-ray, you can see this is the RA margin, this is the heart in heart, this is the LA shadow, hyperinflated lung field, that is a sign of CCF in an infant. And these are the end-on vessels, you can see. And this is the plethora and the prominent MPA. So this is a very typical, and you can see it's the dipping down apex, it suggestive of the LV apex. So this all suggestive of it's a large left to right shunt, and the LLV is getting dilated rather than RARV. So if you see the same thing, reflected on ECG. You can see the left-sided forces are more prominent. And as I explained to you last time in ECG, when there are deep Q waves, prominent R, but the ST changes are normal, that is suggests to a volume overload. In the same way, deep and wide Q, prominent R and the ST changes, that is suggestive of pressure load. Here you can see the ST segment is normal, only the volume of the R is, that is suggestive of volume overload, that means LLV is getting dilated. In VSD, again for revision, because the blood will go from LV to RV, RV will not get enlarged because RV is also contracted at the same time, but the blood will go to PA. So pulmonary artery will get enlarged, again it will return to LA, it will get LA enlargement, then LV, and then from there it will shunted to the RV side. So this is the typical of the VSD where LA, LV and the pulmonary artery will get dilated. In the same way, when the VSD is very large and you not operated for long time, the RV has to work against the hypertension of the pulmonary artery. The RV is also getting enlarged. So you can see in this, the all V2, V3, V5 all having biventricular. Biphasic means both chambers are equally dilated. That is known as the Katz-Wenzel phenomena. That means the biphasic complex is more than 50 mm in V2, V3, V4 is suggestive, and it's suggestive of biventricular forces. So this is a typical, if the VSD not got operated initial, then this is a pre-Eisenmenger phase. Suppose after that you not operate, it will go into Eisenmenger. So this is a Katz-Wenzel. The hemodynamic classification, if we see, if the VSD, there are two classifications. One is related to the NHP because it's comparable to the aortic wall. So 1/3 of the root of aortic, or one it becomes to equal or 2/3 up to the aortic root, or more than 2/3 of aortic. That is known as small, medium and large. When you can see, when the small VSD, LV pressure is always greater than RV. QPQS is less than 1.4. In the moderate, RV pressures are high, but still is less than LV, but the QPQS is more than 1.4 to 2:2. And non-restrictive, when the pressure become both equal, the murmur becomes small, but the PA pressure will be high and the QPQS is more than 2.2. That is known as the large. So this is known as the typical hemodynamic as well as the anatomical classification of the. So you see, these are the general case scenario where that shows how ASD and VSD can present. In the same way, 5-month-old, born premature, poor weight gain, success, excessive, again it's same autonomic instability and there is more flow towards the lung. Weight of 2.7, birth weight was 2 kg, bounding high volume pulses, hyperdynamic continuous murmur and peaking at S2 systolic component other area. So that is typical. Any preterm, the chances of getting PDA getting closed spontaneously is very less because they are lacking the muscle required for closure of the PDA. So in such case, when there is a preterm, the chances of having the PDA is very high. So in the same way, preterm with 5 months presented with failure symptoms, having bounding pulses and continuous, that is typical of the PDA. If you see again, the ECG reflect the same because PDA also, the blood goes from descending aorta to the pulmonary artery, the PA will get dilated. Again, it will come to the LV will get dilated. From LV it will go to the ascending aorta, it will get dilated. But these all dilatation of ascending aorta will seen only after 2 to 3 years. But if you see on the echo, you may able to make out the LV aorta will be enlarged and it's a volume overloaded because it's not pressure over condition. Okay, so you can see this X-ray again. Because LV is getting dilated, it's a dipping down apex, end on vessels you can see up to peripheral 1/3, heart in heart shadow. So that is typical of your LA dilatation, heart in heart shadow. So this is all suggestive. On X-ray, sometimes you may not able to differentiate between VSD, PD, AP window because all will cause LA, LV dilatation. So this is the typical X-ray. So this is, now once you see in the adult age, you can see the aortic shadow also become prominent. Because the aorta is receiving blood for long time, then the aortopathy ensures. So that's what you can see, this aortic dilatation, this aortic dilatation in presence of PDA is appearing only after 2 to or mostly after 5 years of age. So if you see the PDA hemodynamics, you can see this. See, the blood will go from the PDA to the pulmonary artery, then it return to the LA, LV and then again aorta. So you can see wherever the blood flow, then only those chambers will get enlarged. So that is the typical of PDA. So you can see ASD, VSD, how it present. So 3-month-old case of trisomy 21. You have to take the clue from the trisomy 21. So now immediately you should come with the cardiac case. What are the diseases common with trisomy? That is one, AV canal defect, ostium primum ASD, large inlet VSD, TOF and coarctation. These are the 4 or 5 diseases which are very common with trisomy. Present with breathing difficulty, feeding tolerance, one episode of breaking through pneumonia. That means again it shows increased flow situation. dysmorphic faces, hypotonia, baseline respiratory distress, room SHO 9. Again, it's a acyanotic because room is 96. No obvious murmur, but the loud P2 and bilateral cramp. Loud P2, no obvious murmur. I already explained when the shunt is large, so you may not able to hear murmur because the pressure will be equal. So in this typical, you can see the RA is also getting dilated as well as the LV is getting dilated, more flow to the lung. So if you see the X-ray, you may not able to sometimes distinguish whether it is a VSD, large ASD. But if you see the ECG, that is very superior axis. So in cardiology, superior axis is found in only 4-5 diseases, like if you see the tricuspid atresia, AV canal defect, pulmonary atresia, intact septum, and dysplastic wall in pulmonary wall in Noonan and rubella. So once you see there is a negative F, so you can see that the superior axis is and the QRS axis towards the 90 degree. So that is the suggestive one. This dysmorphic trisomy is evidence of large shunt with superior axis, that is typical of your AV canal defect. So this is there. So you can see the same patient, 3-month-old. This is the respiratory. The concept why it's a superior axis because it's not there is a break in the bundle because of the AV canal, the bundle shifted and there is a left hemi block, and that will causes the axis to go superiorly in the initial phase. So this is the hemodynamic. This is the combination of both ASD, VSD. It will be more symptomatic earlier presentation. So once you get the management requires failure symptoms to be treated, and at the age of 3 to 5 months you have to do the closure for AV canal defect. Okay, now the other 2-3 cases. Now 13-year-old known case of CHD. History of recurrent RTI, poor weight gain, advised surgical correction but lost. In between symptoms improved, now presented with dyspnea, exertion, easy fatigability. No obvious sinus examination but room SHO is 92%, no clubbing, RV apex, parasternal pulsation, loud, single and no murmur appreciated, second heart sound is loud. You can see the initial shows the CHD with the high flow situation because poor weight gain, feeding, breathing difficulty, but after 2 to 3 years the symptoms improved. That means what happened, the more flow is going towards the lung, that's why the lungs are getting more symptomatic. But once the lungs PA pressure increase, PVR increase, now it's getting the reversal of the shunt. So once, that's why it's very important to diagnose VSD and all those lesions early and to treat early, otherwise they will go into the Eisenmenger phase. And that is the typical history of Eisenmenger, initial flow of high flow and then it will become restricted and then it becomes more symptomatic because of the desaturation. Although sinuses not appear on your examination, but examination sinuses only appear when the saturation is less than 85 to 88%, and it describes so many on the nail factor as well as the anemia. So once you do the pulse oximetry, you come to know it's a cyanotic heart disease which is acyanotic in the beginning and now turned out to be the cyanotic. You can see this is the same X-ray, large RA, LA, large heart, but it becomes a short heart, and the PA prominent, there is a pruning, that means there is no flow seen in the periphery. So this is the typical transition. Once you won't operate the large shunt post tricuspid, it will go into the Eisenmenger. That is a typical example of this. The same ECG with that showing the prominent left forces, but after 10 years you can see the left forces are converted into right forces and the axis from the left axis shifted to right axis, and the 85% size is a typical ECG of Eisenmenger. So now you can see the ASD how it present, VSD how it present, PDA what will be the history, AV canal and the Eisenmenger. So now another, this is very common. So why the clinical examination is important? 25-year-old presented with headache, found to high blood pressure and started on antihypertension. Nobody, he is following this for the last 1 to 2 years. When comes to the another physician, he revealed no obvious cyanosis, but when he checked the lower limb pulses, he found out the lower limb pulses is very poor. Then we found out there is a radiofemoral delay. So any hypertension or any cardiac patient, it's imperative, compulsory and it's mandatory to check upper limb and lower limb pulses, upper limb and lower limb BP. And when we did, we found out there is a short ejection systolic murmur, click is there. And when we saw the backside of the infrascapular, there is a pulsation. So now the diagnosis is very clear. When the radiofemoral delay, hypertension, upper lobe, upper body hypertension is a typical feature of coarctation. You can see this is a typical X-ray, the figure of 3, because this is the site for coarctation, dilated as a proximal aorta, left subclavian, distal aorta, and there is a prominent aorta. So that is a typical X-ray of that. So if you see correlation with the CT as well as the NG, you are able to find out this is a typical. So what is important point? Any hypertension, any dilated cardiomyopathy, any LV function or any patient, in fact, in your practice, you should check the lower limb pulses so that. And now this is another patient 45. This also missed during initial evaluation, but there are very significant finding. You can see the notching on the ribs, which is found only after 5 to 6 years or mostly over 7 to 10 years, because the collaterals become that much dilated intercostal that it will cause the notching on the inferior portion of the ribs and it causing the notching.